Hello, my name is Amrita Sethi, and I'm the Director of Interventional Endoscopy at Columbia University Irving Medical Center in New York. I'd like to thank the course directors of the International Workshop on Therapeutic Endoscopy for inviting me to participate and speak to you today on direct single operator cholangiopancreatoscopy. These are my disclosures. Indications for cholangiopancreatoscopy include and have included for some time now evaluation of indeterminate strictures, treatment of intraductal stones, and selective cannulation. Emerging indications over the past few years have included preoperative mapping in hilar lesions and IPMN, pancreatoscopy, evaluation during treatment for liver transplant strictures, foreign body removal, and other potential therapeutic uses. Cholangioscopy started with mother-daughter imaging, which did provide insight into ductal epithelium. However, the system was fragile and the imaging was limited. Video cholangioscopy provided us with beautiful imaging. However, the availability of this cholangioscope was limited and also fragile. Then single operator cholangioscopy was developed, first using a fiber optic system and now a digital imaging system, and has really been responsible for the widespread use of single operator cholangioscopy. As I mentioned, the imaging has improved significantly with the different technologies. This was the mother-daughter scope, this fiber optic imaging. Here you see the two generations of digital imaging providing beautiful details regarding the ductal epithelium. Of course, we always still aim for the imaging provided by video cholangioscopy. This was the system, is the system of the fiber optic system known as Legacy, provides 4 channels and 4-way steering. These channels allow for not only the imaging in the case of fiber optics, but diagnostic devices. And this has now evolved into digital cholangioscopy, where the imaging chip is a digital chip at the end of the cholangioscope. Again, it provides a large channel for accessories and independent irrigation and suction channels. So as indicated, indeterminate biliary strictures has been an important indication for cholangiopancreatoscopy. And as you've heard just recently from Dr. Reddy, so I won't go into this in that much detail, but as you know, that 20% of strictures are deemed indeterminate. This is due to the low diagnostic accuracies of biliary brushings. Use and work with video and fiber optic imaging has provided us with vocabulary and as to malignant and benign features regarding the presence of growths, the surface structures, and vascular structures. These were single center studies that did not have validated criteria and were descriptive and had poor inter-observer agreement when tested without clinical context. Digital cholangioscopy has really provided a lot of further detail with regards to surface patterns, evidence of ulcerations, intraductal lesions regarding shape, ulceration, and provides us with the ability to specifically target tissue. And hence, there has been significant work to try to develop consensus criteria, new consensus criteria based on imaging with single operator cholangioscopy to help distinguish between neoplastic and non-neoplastic lesions. These include the criteria developed by Robles Madranda, the Monaco criteria, that imaging using video cholangioscopy and narrowband imaging, and most recently, the Mendoza classification. As you can see, the sensitivities and specificities of the criteria using digital cholangioscopy are similar. The accuracies, however, are quite variable. Most recently, the Mendoza criteria actually combined the criteria of both the CRM system and the Monaco criteria, and narrowed down the criteria to 4 that had excellent inter-observer agreements. And then using those 4 criteria, which included dilated tortuous vessels, raised intraductal lesions, and friability, they were able to determine amongst expert users an accuracy of 77% in determining malignant versus non-malignant lesions. But really the value of all of these classification systems has been an enormous library or atlas of features that can be found during cholangioscopy with specific details to surface patterns, growths, nodules, masses, integrity of the epithelium, and vascular patterns and dilation. In a systematic review and meta-analysis using only digital single operator cholangioscopy, this Brazilian group found that the overall sensitivity was 94%, specificity 95%, and accuracy of 94%. And then in a randomized prospective trial comparing cholangioscopy guided sampling versus ERCP guided sampling, there was a significantly higher sensitivity based on visual impression, as we've seen in other studies previously using cholangioscopy, and also a significantly higher sensitivity in directly in cholangioscopy guided biopsies versus transpapillary or ERCP guided brushings. Other classification systems have been developed to look more specifically at inflammatory or pre-malignant lesions, such as PSC. The Edmonton classification system stratifies lesion strictures into 3 categories: inflammatory, fibrostenotic, and nodular and mass forming, based on their cholangioscopic images and features, and then goes on to suggest surveillance algorithms based on these findings, with close follow-up and repeat cholangioscopy and surveillance biopsies in patients with nodular and mass forming features. One might think, and it is possibly felt, that the value of cholangioscopy in indeterminate strictures is really the value of directly visualized biopsies. Much work has been done by the group in Orlando that looked at using the biopsy sample and performing a smear, and then having on-site cytology evaluate this, and they demonstrated 100% sensitivity with a mean number of biopsies of 3. In a follow-up study called the Socrates trial, they showed similar results could be achieved even in the absence of on-site cytology. Other studies have mixed results. However, this study was performed with a mix of older generation or fiber optic cholangioscopy as well as digital cholangioscopy. Due to the independent accessory channel of the cholangioscope, adjunctive imaging modalities can be used, such as confocal endomicroscopy, that can help provide further information regarding malignant versus inflammatory versus benign lesions with moderate diagnostic yield. Pancreatoscopy has been really having an emerging role. Early work done again with fiber optic and video cholangioscopy demonstrated high technical success in the cohort of patients who underwent this, as well as over 50% of patients having neoplasia confirmed with visually directed biopsies. The sensitivity of the visual impression was 87%, and the combined sensitivity with histology was 91%. In a study in which patients underwent pancreatoscopy for pancreatic duct strictures and dilated ducts in the setting of idiopathic chronic pancreatitis, 13 patients were actually found to have IPMN by pancreatoscopy alone that had not been detected on prior ERCP or endoscopic ultrasound. In fact, 4 patients actually went on to surgery, with 2 patients having cancer and 2 patients having dysplasia, leading this group to recommend that pancreatoscopy should be considered in all patients with idiopathic chronic pancreatitis and dilated ducts in order to allow for duct clearance of stones and to evaluate for potential underlying IPMN. This is an example of a patient who was originally sent for Whipple surgery due to a stricture in the neck of her pancreatic duct with a dilated distal duct. However, on pancreatoscopy, the IPMN features were actually only found in the distal portion, in the body and tail portion of the pancreatic duct, with normal epithelium in the head, and therefore this patient was offered an extended distal pancreatectomy. And thus, cholangiopancreatoscopy is now being used for preoperative assessment. In this study, 34 patients actually had a change in their surgical plan, with 25% of patients avoiding surgery. Stone therapy has been a mainstay indication, original indication for cholangiopancreatoscopy to treat difficult stones, those that are larger than 2 centimeters or proximal to narrow ducts and strictures, or that may be impacted. There are 2 available cholangioscopy-based lithotripsy systems, including electrohydraulic lithotripsy and holmium laser. And the value of performing this under cholangioscopy is that it allows for visualization to ensure contact with the stone versus the wall and prevent duct injury. Results of studies have demonstrated greater than 90% ability to perform complete stone clearance using cholangioscopy directed lithotripsy for difficult stones. And in a study comparing electrohydraulic lithotripsy versus laser lithotripsy, similar efficacy and safety were found. However, a shorter procedure time was achieved with laser lithotripsy. When compared head-to-head, cholangioscopic lithotripsy versus mechanical lithotripsy, there was a significantly higher stone clearance rate with cholangioscopy guided lithotripsy in 2 randomized controlled trials. In addition, when patients were felt to have clearance of their ducts, given a negative cholangiogram, up to 22 to 34% of patients were found to have, in these 2 studies, multiple stone fragments remaining using cholangioscopy. This is an example of a pancreatic stone duct lithotripsy using EHL. You have to bathe the stone in saline, and here you see the imploding, the sort of fragmentation of the stone using the EHL probe that makes contact with the stone itself, and you avoid the underlying epithelium. In a study that looked at the yield of pancreatoscopy for pancreatic duct stones, the technical success was 98%, the clinical success 84%. The procedure time was around an hour, with a significantly longer procedure time when EHL was used. If adverse events were seen in 10% of cases, and if greater than 3 stones were encountered, there was an increased risk of technical failure and an increased need for multiple sessions. Cholangioscopy-assisted guidewire cannulation has been described for multiple uses, including in transplant strictures, in hilar lesions, as well as in cystic duct cannulation, due to the ability to pinpoint the orifice. And other uses in transplant patients include, again, an ability to provide visualized guidewire cannulation, to see stones that may not be seen on ERCP, as well as casts, and diagnose cholangitis and viral and ulcers. In a pre and post cholangioscopy, pre and post stenting of transplant strictures, cholangioscopy confirmed improvement of vascular and inflammatory changes and disappearance of foreign body material after stenting. This group felt that it was helpful to diagnose and plan intervention, but did not help predict response to treatment. Casts can be seen on cholangioscopy where they may not be seen on MRI and can be removed, as can other foreign bodies, including migrated pancreatic duct stents. And now there are dedicated devices available, such as snares and baskets that can fit through the cholangioscope. Treatment options are limited using cholangioscopy. My friends and colleagues in Sao Paulo have demonstrated use of directed steroid injections into refractory transplant strictures with a limited success. It's important to keep in mind the complications, which do include cholangitis with an increased rate when performing cholangioscopy, and therefore antibiotics should be given or are given routinely when cholangioscopy is performed. In conclusion, cholangioscopy has important diagnostic role in evaluation of indeterminate strictures, as well as in treatment of difficult biliary stones, pancreatic duct stones, and establishing duct clearance. Preoperative assessment is a growing indication, and pancreatoscopy is also evolving both for therapeutic and diagnostic roles. In the future, we look forward to perhaps some improvements using artificial intelligence, as well as additional therapeutic options. I thank you for your time and attention. And again, thank you for the invitation to participate.